Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Dr. Yeshi received a DDS in China in 2011, followed by a 3-year postgraduate training in prosthodontics with a master's degree. Afterwards, she came to the United States and completed an advanced program in international dentist in implant dentistry at the NYU College of Dentistry from 2014 to 17. Then she accomplished a periodontal training in postgraduate program in periodontics. So you've done a program, you have done the dentistry, dental degree, you did the prosthodontics, you did implant dentistry, and you also completed an periodontal training, same at the NYU College of Dentistry in New York. She's a diplomate of the International College of Oral Implantologists and a member of many organizations in prosthodontics and periodontics and implantology. She's been invited to lecture nationally and internationally, and has published several articles in peer-reviewed journals. Dr. Yeshi, it is a privilege to have you once again. This is good.
Okay. So good morning, good afternoon, good evening, everyone, no matter where you come from. And thank you for coming again to join this part 2 lecture of functional and aesthetic crown lengthening. So I'm gonna start today's content right now. So last time we talked about some very fundamental concept about crown lengthening, which is a procedure used to expose greater tooth structure while maintaining the biological width. So last part 1 lecture was focusing on the aesthetic part. So today I'm mainly gonna focusing on the functional part. So first, I want to clarify about how to determine the functional crown lengthening, aesthetic crown lengthening. For me, it has nothing to do with where the surgical area is. It really depends on the purpose of the surgery. So if your purpose of the surgery is to expose more abutment tooth structure, to expose the fracture line or the restorative margin to make the tooth from non-restorable to restorable, then it is a functional crown lengthening. Compared to aesthetic crown lengthening, it's purely just for aesthetic. And for the bone reduction, functional crown lengthening requires 360 circumferential bone reduction, while the aesthetic crown lengthening only requires the bone reduction on the facial because it's only for aesthetic purpose. So for example, if you have a tooth has a very short root in the anterior area, like lateral or central, as long as your purpose is to make the tooth restorable, it is a functional crown lengthening, even it's in the aesthetic area. So first I want to throw a question to the audience. And this is a 35 years old male and came to the clinic with the chief complaint that the crown of lateral incisor always comes out. So as you can see here, there's a crown and with a post that has been fabricated for many years. So recently, patient has encountered several times that the crown came off. So he put it in with some like sort of super glue, but it just kept coming off. So patients say, I wanted to put the crown back, reglue it, or somehow just make a new crown for me. So of course, when I remove the crown, when a resident remove the crown, and this is what we see. So basically, you see a residual root of lateral central incisor. So I want everybody to take a look at this case and think about it a little bit, and think about if you were the dentist, how will you treat this case? And in the end, after today's lecture, we're gonna take a look together about this case. Okay. So last time I started with the concept of biological width and how much bone reduction is needed for the crown lengthening procedure. So as I mentioned last time, the biological width, which is changed to the new terminology as supracrestal tissue attachment, according to the new word classification. So basically it has an average mean of 2 millimeter, like 2.04 millimeter based on Gargiulo in 1961. And you need to give room around 0.5 to 1 millimeter for the bevel. So adding everything together, based on Ingber 1977, you need at least a 3 millimeter for bone reduction for every crown lengthening, no matter it's aesthetic crown lengthening or functional crown lengthening. Here I want to clarify is this 2.04 millimeter based according to the Gargiulo. This is an average number. It doesn't mean everybody has the same number. Now, actually, this number varies quite a lot. You can see some people has 1 millimeter biological width and some people can have a 4 millimeter biological width. So it's really a large range for biological width. But today, just to be able to deliver the message simple and to give you a concept about how exactly to do the surgical procedure, so I will still use the 3 millimeters as our rules for the bone reduction, okay? So last time I also mentioned some clinical features of violating biological width. It includes some chronic pain after crown insertion, some linear gingival inflammation, as here it shows, only around the restoration, and localized gingival hyperplasia, bleeding on probing. And if you don't treat this early symptom soon, and then eventually it will become gingival recession, pocket formation, and the bone loss. Here's a very common example, and you probably will seen it in the or encountered in a clinical daily practice. Is, for example, there's a molar and the crown comes off, so you have to do a new crown for the patient. And of course, there's secondary caries or like restorative margin, restorative material that you want to remove. So you try to place the margin very deep, and you prep the tooth more and more. And then eventually it was a lot of too much bleeding. You cannot see it. So you use a retraction cord, laser, sort of like hemostat, and just control the bleeding and really push out the gum and prep, make sure you prep very clear margin and taking final impression, deliver a crown. However, this is a typical case of violating biologic width, because you're trying to see the margin and push away the gum, but you didn't correct the bone. So as you can see here, when the final crown was delivered, there's always a pocket here and the furcation involvement. And here's the second case. Sometimes you may not be the person deliver the crown, but you may have the person, maybe you are the dentist that have this sort of patient that telling you, I had this crown recently done, but my gums always inflamed and swelling, and there's a bleeding, and I feel so uncomfortable. So doctor, what can I do? So some sort of patient will present in your clinic with this chief complaint, and you see those gingival super hyperplasia. So you know this is probably most likely the treatment for this patient will be surgical correction to establish a new biological width. So those are the case which has the indication of functional crown lengthening. So as I mentioned again, the indications for functional crown lengthening include insufficient tooth structure, subgingival fracture, deep caries, and as well as some cervical root resorption. And of course, there's some contraindications, and the first one will be the poor crown root ratio. So if you make a measurement on the X-ray, on the PA, and you see after your bone reduction, the crown root ratio will be less than 1:1, and you know probably this tooth will not be a proper indication for the crown lengthening. And second one also is very important parameters is the furcation evaluation. If after crown lengthening, there's a highly chance the furcation will get exposed, and this is also a contraindicated with the procedure of functional crown lengthening. And another two will be the root proximity and also compromising of adjacent tooth, which I will elaborate on those contraindications in the future slides. So there are several different surgical techniques in the classic literature and also recently. So today, mainly I will talk about this three surgical technique. One is the Ingber in 1977, which is also the most commonly used surgical techniques in functional crown lengthening. And second one is Wegenber, who proposed in 1989. And last one is Dr. Daniel Melker, who mentioned this biological shaping in 2001. So let's start with the most classic one of Ingber 1977. So there's a concept, like a common mistake that people like for who haven't really done this procedure, you always have a common mistake is how will you correct the bone? For example, let's look at this diagram that you have a healthy biological width for the tooth, for the periodontian, and blue indicating the biological width. And all of a sudden you have a root decay or some marginal caries or fracture or whatever, or restoration material that you wanted to do the bone reduction and to correct the biological width, to maintain a healthy biological width. So in your mind, you were thinking, I should only reduce the bone where the caries is located, such as the red line marked, which is actually wrong. The correct way to do the bone reduction is actually has to include the neighboring teeth. So as this green line listed, as you can see, I not only remove the bone at the requested site, but I also touch the bone around the adjacent mesial and the distal tooth, like especially at the proximal site. The reason behind that is the periodontal architecture that we all learned back to the dental school. So we know there are these three architecture, positive, flat, and negative. In the healthy dentition, the ideal architecture will be the positive, which means the interproximal bone level is higher than the buccal-radicular bone. And for the flat architecture, it is not ideal, but it is acceptable. So you will still have a healthy periodontium. However, the negative architecture, which has the interdental crater. So here you can see the interdental bone is lower compared to the buccal-radicular bone. So those architecture are often seen in a periodontal disease patient. So this architecture is something that we need to avoid. So if you do the bone reduction as this red line, you most likely will end up with a negative architecture. That's why we have to avoid it. And the green line indicating the proper reduction of functional crown lengthening. And the second situation we often encounter is residual root. For example, you can have this root either in premolar or molar or even anterior area, as I showed of this lateral case. So sometimes you may find the interproximal has a good amount of bone tooth structure, but the buccal or the lingual will be very low, like almost like equal gingival, even subgingival, such as a fracture. So the wrong way to do the bone reduction is only reduce the bone at buccal. So this is wrong. And the correct way is to do the bone reduction following the green line, which, as you can imagine, you have to touch the proximal bone. Even the proximal structure is sufficient. And the reason behind this is because we try to avoid the tissue rebound. So tissue rebound, I mentioned this outcome in the part 1 slide, and hopefully part 1 lecture. Hopefully you remember these two cases. Those are two aesthetic crown lengthening cases and indicate that compared to the immediate after surgery, that in the very short term of period, that you actually have quite a lot of tissue rebound. As you can see here, the gingiva has become very coronally positioned and rebound, and the patient has all those soft tissue regained and cover the tooth structure. So tissue rebound is something that no matter in functional crown lengthening or aesthetic crown lengthening, we really want to avoid. And there's many articles talking about this outcome. So you have some author has a very big number, for example, 1 to 3 millimeter, and you also have some author that has minimum rebound. So today we're going to take a close look of Lanning article in 2003 because it has the least rebound of 0.26 millimeter, which almost like you don't have a rebound. So let's take a look. How does he conduct this study and have this outcome of almost zero rebound? So this is the title of the article, and I really highly recommend you read this article. It is very good written, and I really like the study design also. So as you can see here, there's three teeth. One is a treated tooth and two adjacent tooths. So they not only study the treated tooth, but they also study the non-treated tooth, adjacent tooth, sorry. So in the article, they conclude that the tissue rebound is only 0.26 millimeter, and 3 months is enough for the healing, even in its anterior area, if sufficient osseous reduction is achieved. So I'm going to just quickly explain this study design a little bit. So as you can see here, you have a treated tooth, our design tooth, and here you have an adjacent tooth. So there are together three sites: non-adjacent sites, adjacent site, and treated sites. So what they did is they put a fixed reference stent that they fabricated on top of the tooth, and they used a probe measure the reference point to the bone crest. So the blue line indicates initial, the baseline, that you haven't touched the bone. And the red line indicated that after the bone osseous reduction, then the distance. So as you can imagine, in the very beginning, the number can be like 9 or 8 or 7. And after osseous reduction, it will be like 11 or 12. So it will be longer because the distance, the bone crest is further away from the reference stent. So they're compared to 6 different numbers of each site. So here's the table of the result. So the first table indicated the distance from the reference stent to the crest bone. So if you look at the treated size, which is this tooth, so you see the blue line that I just showed was around 9 millimeter, and the immediate after surgery, it's around 12 millimeter. So which indicated the author in this study, they make sure in the treated side, there's a 3 millimeter osseous reduction. And if you look at this distribution table of bone removed for the treated side, there's more than 90% tooth that the bone reduction is more than 3 millimeters. 26% of the bone of the tooth, the treated side, has been removed 4 millimeter, and even one case they removed 5 millimeter osseous bone. However, what I wanted to point it out, and it is very interesting to me, is the non-adjacent side and adjacent side, which is this one. It's very far away from treated tooth. If you look at the non-adjacent side, the baseline is 9.5, and the immediate post-op is almost 11. So even at non-adjacent side, they remove quite a lot of bone. They remove up to 1.5 to 2 millimeter bone. And if you look at the distribution and focus on the non-adjacent side, remember it's here. It's far away. It's not close to it. It's one tooth behind, mesial and distally. So at non-adjacent side, there are, like, if you look at here, almost every tooth they touched it. Only 19% of the tooth they didn't touch bone, and the remaining 80% of the teeth they all removed the bone. Either remove one or some, like if you look at here, 20% of the side they remove the same amount of bone as treated side. So if I make an illustration here on the diagram, this basically is how they remove the bone. Actually could be even more aggressive. So as you can see, even the side is only one single tooth, but to perform this functional crown lengthening properly, you really have to including the mesial and distal adjacent tooth. It's not something that you only can do the bone reduction at a single site. So this is a diagram from that I get from the Ingber 1977 article. And here also you can appreciate that back to the 1977 when this technique was proposed, the author also mentioned the same, that the bone reduction is never only localized in the treated side. It's always including the neighboring tooth because you want to maintain this positive or flat architecture and want to control and avoid the tissue rebound. So this two diagram indicate the proper osseous reduction as the red line show. If it is for single tooth, single root tooth, for example, premolar, this is how you should reduce the bone. And if it is a molar, and you have to make this scallop shape of osseous reduction because you want to protect the furcation, which I will elaborate a little bit later in detail. So the key of functional crown lengthening has following points. First is to establish a restorative margin and a finish line, because this will be your surgical guide. It will be your guideline to tell you how much bone you have to remove. And the second is you have to do a sufficient bone reduction for the treated tooth and adjacent teeth. And third is you have to maintain a positive or flat architecture, never negative architecture. And the last and also very important part is the furcation management, which here I want to mention a term as critical distance from furcation. So this term of critical distance from the furcation, CDF, was first proposed by DeBart in 2003. And this is a distance from the furcation entrance to the margin of temporary crown, which is very easy to understand. So here, basically, as you can see, the CDF is this blue line. It's from the restorative margin and to the furcation entrance. So based on this article, the author says you have to have at least 4 millimeters for the CDF. So if you have a secondary caries or fracture at proximal site, which usually you are safe at a furcation area, and your CDF will be more than 4 millimeters. The only thing you need to do is you need to make sure during the procedure, you cannot remove too much bone to expose the furcation. You have to have at least 1 millimeter bone covered at a furcation entrance. So usually if the caries or the fracture line is at the proximal, the furcation is relatively safe. However, if you do have a caries and fracture line exactly at the buccal or the lingual and on top of the furcation, then you really need to measure it on a PA to determine if the CDF is more than 4 millimeter or less than 4 millimeter. So basically, the step one for the functional crown lengthening is you have to determine if this tooth is restorable or not. So you have to check the crown to root ratio prior to this procedure, and you have to check the abutment tooth height, make sure that you are able to remove sufficient bone and to be able to expose around 4 to 5 millimeter tooth structure. And also, if you are about to do a post, you need to have a 2 millimeter ferrules. So as a restorative dentist or even a surgeon, for whoever is going to do the crown, you need to first evaluate on a PA and determine if patient even have this opportunity or not. Because if you look at this tooth and you get this case and the root is so short, there is no way you can achieve a proper crown to root ratio. You don't even need to give patient an option or refer the patient to a surgical dentist. You can decide, make the decision, tell the patient, I'm sorry, your root is too short. There's no way I can do a crown lengthening, and I will have to extract the tooth. So you already eliminated the option of crown lengthening. And step two is a periodontal evaluation, which include you need to examine the periodontal health of the treated tooth and adjacent tooth. And you need to check the CDF at the furcation area. And also you need to check the mobility of the adjacent teeth. Because you remember, as I said, the bone reduction is not only localized at the treated tooth, but also included adjacent teeth. So if the adjacent teeth already have a 2 or 1+ mobility, and after reduce the bone, you're going to have a more adjacent mobility at the adjacent tooth, which probably will be a contraindication for the functional crown lengthening. And step number 3 it sounds simple, but it's very important, is to discuss with your patient. You have to let the patient know the advantage of this procedure. First is, I consider has a longevity for the young patient, especially for the young patient. And it has a much shorter treatment time compared to the implant. Imagine if the side it doesn't have a lot of bone, you have to go through bone graft, the sinus, and everything. It probably will take a year for the patient finally to get a crown. But for crown lengthening, it's relatively shorter, and it has a less maintenance visit. And most important thing is you can prevent peri-implantitis because you don't place implant there. And of course, there's certain disadvantage for this procedure, which you also have to tell the patient, is that you may have the sensitivity and recession of adjacent teeth if the teeth are vital. And you're compromising the periodontal support not only on the treated side, but also at the adjacent side. And the third is you compromise the future implant placement, because let's say if something happened to the tooth, and eventually 2-3 years later we have to extract the tooth, but you already reduced quite a lot of bone structure to be able to restore the tooth in the beginning, right? So the step 4, so after you discuss with patient, and patient said, okay, I understand the benefit and the risk, and I still wanted to do it. And then this is the time you start to really do the functional crown lengthening on the treated tooth. So the step 4 will be the margin preparation. So as the restorative dentist, you will have to prep the tooth with a clear restorative margin, because this will be your surgical guide. There's no any other surgical guide, such as removable Essex or digital design guide. Is basically the surgeon just need a clear restorative margin as their guide. And of course, after you prep the tooth, you fabricate a provisional and cement with a TEMBA. So here's the example, and the case is anterior, but the concept is the same. So as you can see here, the restorative dentist prep the tooth with a very clear margin and deliver a provisional and send this patient to the surgeon for the crown lengthening procedure. If you are the one doing the surgery, then this is your first step. And then you can go ahead and schedule a second appointment for the patient to do the surgical procedure. And step 5 is a surgical procedure. And first, again, as I mentioned, you have to have a sufficient osseous reduction, which is at least 3 millimeter from the restorative margin to the bone crest. And second is you have to preserve at least 1 millimeter edification. And then last, you have to maintain positive or at least a flat architecture. And here's also the elaborate example of the surgical procedure. As you can see, during the surgery, the doctor has to remove the provisional. Unlike aesthetic crown lengthening, that you can leave the provisional aside, but for functional crown lengthening, you have to remove the provisional, because for the posterior tooth, there's no way you can reach the proximal if the crown is at the side. Right? You can imagine that. So the provisional has to be removed during the surgery. Therefore, it really requires you to have a very clear margin, and therefore you can guide the surgeon, like tell them exactly where you want them to relocate the bone. So after surgery, then the surgeon will be able to put the provisional back and suture back the flap, and patient will go home to heal with the provisional. In this situation, we don't really have aesthetic issue, because the case will be mainly in the posterior, unless it's in the anterior zone. Then patient will have the issue of black root or maybe a little bit sensitivity. But this is usually the step that you will have to do for the functional crown lengthening. However, oftentimes in the clinical setting, what you encounter is something like this. You may have a fracture very deep, or like insufficient tooth structure that you cannot prep at all. Like the gum is so thick, especially for posterior molar, and you couldn't even see, if you prep deep, and it will be a lot of blood. So oftentimes the restorative dentist cannot even prep the tooth with a final clear margin. So in those cases, we'll have to modify the sequence a little bit. And so now I'm going to use a clinical case just to elaborate a little bit more about the detailed sequence that how I will do a functional crown lengthening. So this is a functional crown lengthening referred to me for the mandibular second molar. So if you look at the clinical picture, it looks normal. Like, I mean, the buccal looks pretty sufficient tooth structure for me. It doesn't look like the case needs crown lengthening. But if you look at the X-ray, you can appreciate that the dentist cannot really prep the mesial and distal proximally because the gum is so thick, if you look at here. And I believe many of you have the same experience as I do, that the most difficult tooth to prep is the distal of the second molar. No matter it's for surgery or for normal prep, I think that is oftentimes it's very difficult to prep. Even you don't need a crown lengthening, it's very hard to prep. Let alone you have a very thick gingival covered every tooth structure. So that's how the prep looks like when the patient sent to me. Of course, this is not a final prep, and the restorative dentist will drop the margin more after I do the surgery. But if I do the surgery based on this margin, then it will be insufficient osteoreduction. And later on, when the restorative dentist drop the prep the margin even deeper, and it will violating a biologic width. So what I want to hear from the restorative dentist is to send me a message or write in the referral note saying, Dr. Shi, I would like to drop the mesial margin 1 millimeter more and distal margin 2 millimeter more. So the restorative dentist will give me a concept that, oh, I want you to drop this, or future, I will drop this. And then I can do all this mathematic or line and join on a PA, and to calculate or to imagine and picturing how much bone osseous reduction that I need to do. So for this case, when I raise the flap, the first thing I do is not to touch the bone, is touch the tooth. So I basically just grab a chamfer and start to prep the tooth. And for the prep, you don't need to prep like for the final prep with a very good shoulder or something. The only thing you need to prep is just to make sure the margin is clear for you, the surgeon itself, to be able to see where's the margin. And therefore, they can use the margin as a guideline to guide them to reduce the bone. So as you can see, this is the initial prep, and this is after I prepped once the flap is open. Once the flap is open, it's super easy to prep. You see every tooth structure, and if you control the bleeding well, you have less issue with the visualization also. So once I have a clear margin circumferentially, including the proximal side, and I will start with my two surgical burr. One is the end cutting burr that I showed in the last lecture, and the second is my round burr. And then I will use like the 3 millimeter as my guideline to continue to start with the osseous reduction, and make sure at the furcation area I have a 1 millimeter. So here you can see this scallop shaped osseous reduction. So just want to remind you again, here's are all the burrs that you can use for the crown lengthening, no matter it's aesthetic crown lengthening or functional. So these are the end cutting burr that you only cut at the ends. You may have those like end cutting burr has a long shank, or you can use this end cutting burr, which basically is 4 millimeters or 3 millimeters. There's a different length of the shank, and you can even use this shank as your guidance. So once you reach this point, you know, okay, fine, it's enough, it's done. I have my 3 millimeters. And then after you reduce the bone osseous reduction, you do the osseous reduction with and cutting burr, and you will have this ledge of the bone that you have to smooth it out. Either use a carbide or use a diamond. I personally would prefer diamond because it's more detailed, smooth, and not very aggressive. Carbide is, of course, is usually more aggressive than the diamond. So it's up to you. If you have a huge ledge and has a lot of bone to reduce, probably will start with carbide because it's it's more efficient. Otherwise, I would recommend you to stay with diamond. So these are the pictures on the day of the surgery, and with immediate post-op and 3 weeks post-op and final. So one question and people may ask here is, how can patient wear provisional? Yes, because I reprep the tooth during the surgery. So imagine a patient come with a provisional that the restorative dentist made for them. But once I drop the margin, the provisional will no longer fit the tooth. So here you have a two situation. You can reline a provisional. Either you can reline a provisional during the surgery. Once the flap is open, you can reline a provisional. You can even cement a provisional, because then you can remove all the excess cement when the flap is open. Then you just close the flap, suture everything below the provisional. So that is definitely the best way to do. However, in US, it might not be easy because the surgeon might not want to do the provisional reline because it costs a lot of chairside time, and also he probably wanted the restorative dentist to do it himself. So if you are the restorative dentist and a surgeon, I probably will recommend you to do in this way, because in this way you can protect the tooth and the patient also have a less discomfort post-op, have less post-op discomfort. And if you don't do it, and the second time you can do is at 2 or 3 weeks post-op when you remove the suture. So once there's no more suture, you can go ahead to reline a provisional and then deliver the new provisional and let the patient go through the healing process and eventually do the final impression and the final crown. The key for here is this picture. As you can see here, you can see the clear margin here. And compared to immediate post-op, you almost can see a little bit of recession rather than the tissue rebound. So it is not a bad thing. It is a good thing. As a surgeon, when you call patient for a 3-week post-op, you wanted to see a clear margin that is super gingival. You don't want to see a margin was covered again by the soft tissue. Therefore, that probably is a sign telling you that you may not do the sufficient osseous reduction. So once everything is above the gum, and you can do provisional reline, you can reprep, you can finalize the finish line, you can do everything super gingival. No blood, clear, visualization, everything will be easier. So again, sufficient osseous reduction is the key for functional crown lengthening. So here's the initial situation, and here's the final crown. And here I wanted to look at adjacent tooth, and you can really appreciate how much recession that tooth has occurred on this adjacent tooth compared to the initial. And if you look at the X-ray, the comparison of initial and the final, and you can see how much a bone reduction that I have done, not only on the treated side, but also on the non-treated, like adjacent side. And although it's really quite a lot of osseous resection, and imagine like nowadays we're talking about we want to do GBR to get 1 or 2 millimeter bone, and I just easily use a burr and remove 3 millimeter bone. So yes, and some people say it is an aggressive technique, but for me, I do think this tooth will last very long. You see the margins are so clear. There's no overhang. And biological width is very well respect, not only for this tooth, but also for another tooth. So I really like this procedure, and compare that I take this tooth on a place implant and I don't know what's going to happen to implant. So this is another case, and then showing you that the intraoperative preparation, the most of dentists cannot really prep because the gum is in the way. And as a surgeon, you will have to prep the tooth again to create this new finish line to be able to guide you for the osseous reduction. And this is another case, and the patient was referred by the crown lengthening. And then the special for this case is that not only the patient needed crown lengthening on premolar and a little bit on the molar, but also there's a soft tissue dehiscence on the buccal. So this is what you saw once you raise the flap. So for this case, I not only do the osseous resection, but I also did a little bit of odontoplasty on this root because it is very outside the bony housing. So after I did the odontoplasty, I harvest the connect tissue graft from the palatal and put it on the buccal. And therefore, I not only treated for the hard tissue to maintain a healthy biologic width, but I also treated the soft tissue dehiscence to make sure there's a thick biotype around the tooth. So, instead of like taking out the tooth, place an implant, I managed it in a relatively, I would say, atraumatic way. And I believe these two teeth will have quite a very good prognosis in the long term. And again, here's showing the blue line indicated the previous initial bone level, and the red line indicated the final osseous bone level. So basically, this is the Ingber in 1977, which I call it the 3 mm rules. So in this way, if I really listed each step, you have all those 6 steps. You first need to have your restorative evaluation and a periodontal evaluation. And after this 2, you will have to determine if the crown lengthening is an option for the patient or not. Once you determine, okay, fine, I can talk with patient about this procedure, then you have to discuss the advantage and the disadvantage with patient and let a patient to make this decision. And eventually, if you really decide to do for it, you have to first establish the clear margin and then go ahead to do the surgical procedure and eventually finish the final restoration. Now, next, let's do a little bit about Wagenberg in 1987. Okay. No, sorry, 1989, 5 mm rules. So here's some picture illustration to showing you how this technique is exactly being conducted. So you basically have a very short root, or let's say fracture. So what Dr. Wagenberg do is he will use a very narrow chamfer burr and go circumferentially around the tooth to create this sort of, he called it trough. So this trough is created within the bone with a 210 and 10P diamond burr. Once this trough is created, and he will check with the depth of the probe, make sure he reached a certain depth he wants, and he will use this round burr number 6 and number 8 and go circumferentially to eliminate this trough. So this is the osseous reduction that he is doing. And then after he removed this trough, and he will make sure he exposed adequate tooth structure around 5 mm. So remember, his 5 mm is not talking about from the margin to the, is not from the restorative margin to the bone, it's the tooth structure itself. So therefore, then you can continue to do the post and the crow and the crown. And the tooth key feature that I want to highlight here is first, this is the burr that he's using, 210 and 10P. And this is the trough. If you can see here, it's a circumferential groove around the tooth. And once this trough has created and he measures with the probe, make sure he reached a certain depth he wants, he will use round burr to remove all those non-supported bone. And eventually he will find that, okay, I have tooth structure around 5 mm. So here, the thing that I want to point out is this 5 mm is not from the top of the tooth structure. It's from the lowest level of the residual root. So here, this 5 mm rules is indicated the tooth structure, not the whole total length, not only talking about the margin to the osseous crest. So what I think is very smart of this technique is once he creates this trough, he will check the tooth mobility, and then he will modify the treatment based on the mobility of the tooth. For example, if it is the tooth, let's say canine or premolar, that you couldn't tell from the PA if the tooth can have a proper crown to root ratio or if the tooth can become mobile or not, he will do this trough and check the mobility, and then he may change the treatment option. He may tell the patient, so listen, I already removed the bone. I think there's a lot of mobility of the tooth. The tooth is not going to last long. And then he will talk with the patient during the surgery and change the treatment plan to extraction. He can change the treatment plan to extraction. He can immediately place implant, or he can change the treatment to the root amputation or hemisection. So this is the part that I think is very smart. And then after he created trough, he will use this round burr to do alveoloplasty. And then last but not least, he actually did a lot of odontoplasty, if you hear. He basically used a chamfer burr to remove all the previous margin from the left from the previous restoration. So as you can see here, in his technique, there's no such thing about the restorative margin. He doesn't need a restorative margin as a reference. He actually removed all the old restorative margin. The only reference he needs is the lowest point of the tooth structure, and he wants to make sure the lowest level of the tooth structure has at least a 5 mm distance away from the bone crest. So this is Wagenberg's technique with the 5 mm rules. So if there's a 6 step for the Ingber 3 mm rules, I consider it as only have 3 steps for the Wagenberg 5mm rules, because basically you don't need a restorative dentist. You don't need a restorative evaluation. You don't need a periodontal evaluation either. He will evaluate during the surgery after he created a trough. So no matter if the tooth is restorable or not, he doesn't care, because as long as I have 5mm, the tooth of course can be restorable. And so all the discussion will happen during the surgery, and then he will do the surgical procedure and then final preparation. So that's the concept of Wagenberg 1989, which is, I think some classic old periodontists are still using this technique, but for us, it's not really very common to use, because as you can see, it's very hard to use this technique in a single tooth. It's mainly requested for a lot of bone reduction for the adjacent tooth, and it's less cooperation with restorative dentists, which in US, it's the opposite. Like you really have to talk a lot with your referral dentist. And last, and I will use the last couple of minutes to just talk quickly about this Melker 2001 biological shaping. So if I say Inkberg in 1977 is mainly alveoloplasty, and Wagenberg 1989 is actually alveoloplasty plus minor odontoplasty. However, for Melker 2001, it's actually minor alveoloplasty, but major odontoplasty. So I just want to show you quickly to give you concept how Dr. Melker exactly do his cases. So for example, if you have a tooth structure that is very, it's a shallow, that you don't have sufficient tooth structure, and you have some restorative material like subgingival or on the root surface, what he does is he uses a burr to trim away everything. Nothing left, no restorative material, no concavity, no developmental groove, no cementing, everything removed. And this is for the furcation area. You see here, there's a shallow furcation. What he does is he uses a burr to trim away all the tooth structure until he sees bone. Then here's a quick case that I get from his chapter and online. All these cases can be searched online. You just need to search Melker biological shaping, and you can find a lot of detail about this case. And also Dr. Melker has his own courses to discuss about this procedure in detail. So I will just give you a brief introduction. So here, as you can see, the several tools are continuously needs crown lengthening because they're short. So what Dr. Melker will do is use a burr just to completely remove all the previous restorative margin, and together with all the developmental groove, calculus, cementing, cementing enamel project, everything removed. And then he will use a fine burr just to polish the tooth structure, and then eventually use a round burr to start to reshaping the bone. But here, he doesn't reduce a lot of bone. It's really just enough, a very light touch, and to be able to maintain a positive architecture. That's it. He eliminated any shallow crater and make the periodontal bone architecture as positive, and then he closed the wound. So this is what you look like, and what it look like after the odontoplasty. And he will suture his flap with a periodontal anchor suture, and this is immediate after surgery. And eventually, the soft tissue will rebound for sure. And it will rebound certain amount of soft tissue. That's the body created biological width by itself. Therefore, he didn't give any number of 3 or 5 or 4. He will let the body create a biological width by itself, and then eventually fabricate a final restoration. So the key for this concept is using this technique, you minimizing the bone reduction. You don't do huge alveoloplasty, and all the margin will be supragingival, and eliminating previous restorative margin, developmental structure, and furcation anatomy. And they will remove all the CJs also. So there's no enamel at all. It's all dentine exposed. And then advantage for this technique is that it is less bone reduction, and it respects the individual biological width instead of using a 3mm rule or 5mm rules. It's really based on your body healing. And the best thing for this technique that I think is treating shallow furcation. For example, in this case, as you can see, there's almost class grade 1 or 2 furcation at the maxilla molar. And then you just use a burr to trim away all the tooth structure until you see a healthy bone around the furcation. And this is how eventually the crown shape will be from the occlusal view. So the final restoration actually follow the shape of the tooth. And here's a quick scheme diagram to showing that's the concept of how biologic shaping and to treating the shallow furcation. So here, that's the groove that you make. You basically cut off the whole tooth structure and the root structure to eliminating the furcation involvement. Of course, there's a disadvantage for this technique. First, it's a severe odontoplasty. And also there's no requirement for this 2 mm ferrule. So is it a like long-term regarding the longevity of the restoration? I don't know. There's not really a study about it. And also the most difficult part is you really need a good technician, a pros team, and to fabricate this very high quality of prosthesis. Everything is, the margin is super gingival and everything is chamfer. There's no shoulder, almost no shoulder. And he does a lot of PFM also. And also another thing is like so far there's only case report and series, and there's not really clinical trials or long-term studies. So I think it is a very interesting and a good technique, but I think it needs a further study on it. So finally, came to my summarized slides. So as I mentioned, the Melker's biologic shaping, including minor alveoloplasty and with major odontoplasty. So here are the steps that I summarized myself. And so you still need a restorative evaluation, periodontal evaluation, discuss with patient, but you don't need to establish the new margin, restorative margin, because you trim away everything. So you can directly jump to the surgical procedure and then wait soft tissue healing and do the final restoration. So here's the summarize and comparison of the 3 technique. Still, right now in Burr 1977, the 3 mm rules are still the most commonly used technique in the functional crown lengthening. And again, as I said, there's an advantage and a disadvantage regarding the surgical procedure. So those parts that you have to really understand it and talk with your patient, and eventually to come out with the proper treatment plan and a most ideal treatment plan for a patient. So after today's like this talking about the crown lengthening, like some of you might think it sounds like a very difficult procedure and aggressive, because you remove a lot of a bone. So why don't we just take out the root and place implant? Of course you can. And personally, my specialty actually is place implants. So I do place a lot of implant too. For example, like this case, also very young patient, like 30 years old, a female, and then the crown came out and she asked me what's the option for the tooth. She really wants to save the tooth. I was like, yes, I can do crown lengthening because the furcation is not a problem. And I just need to reduce a lot of bone at the proximal. But I told her to do crown lengthening, I have to touch the bone of the neighboring tooth. So after discussion, the patient doesn't want to do crown lengthening anymore. So she's like, oh, fine, I don't want to touch my bone of other teeth. I want to, everything happen just on this tooth. So what I did is I took out the tooth, I did a socket graft, and wait for 3 months, place implant, wait for another 3 months. So approximately like 6 to 7 months, and I delivered the implant crown. And patient was very happy with the result, and it has been like 2-3 years post-op, so no problem for it at all. And another case also for a young patient, not dental, like a university student, like college student. And the maxilla first molar has this fracture and like, at the proximal. So I told him I can do a crown lengthening, but I have to remove a lot of bone and you have to go through root canal and post and crown. And he's like, no, I don't want to do that. I hate root canal. I don't want to do it. And I don't want to touch the bone. So I say, fine. And then we did all the surgical procedure, extraction, weight, and socket graft and the sinus. And then if you look at the massive sinus, I actually waited for 7 months for it. So the whole treatment lasted more than a year. And eventually patient is happy, has a crown, but during the 1 year, patient doesn't have tooth. So can we place implant? Of course you can. Will patients accept the implant? Yes, of course. Patient, as long as you discuss everything with patient, some patient will actually prefer implant. However, what I want to show you is the slides. Like for the past years in NYU, that I treated so many peri-implantitis, and many of the are also actually my cases also. Like I don't feel bad to tell you. Like personally, I encountered the peri-implantitis on my own implant or from the others. So if you haven't seen anything in your clinic, either you haven't placed enough implant, or the implant you placed and the patient had issue and they go to another dentist, So peri-implantitis, I think, is almost inevitable disease that in the nowadays with so many implants has been placed. And unfortunately, so far, we don't really have a very predictable way to treat it. So please think twice if you decide to place implant for a patient. And even the crown lengthening sounds like an aggressive procedure. And last, I want to close my presentation with this case. So as I explained, basically there's a residual root for this lateral incisor, and I'm really curious in your mind what is your treatment for this case. And unfortunately, I didn't create a poll. Otherwise, I would be very interesting to see. So this is actually not my case, and I really appreciate my friend shared this case with me. So I'm gonna show you how this case being treated. So of course, the dentist didn't want to do any crown lengthening because he think, oh, it's an anterior area, I have to trim all the bone around the nibbling tooth. So no, let's take out the tooth and place the implant. Okay, fine. They took out the tooth, placed the implant. And unfortunately, the implant failed. And peri-implantitis infection failed, and actually create a very huge defect for the site. As you can see, here is a combination for severe horizontal and vertical defect. So then the dentist has to do a massive bone graft, the remembering, and a lot of biologics, and to try to rebuild the bone and place the new implant. And of course, it's never enough. You have to do a soft tissue graft, connect tissue graft, and there's no calcaneus tissue graft. So there's no calcaneus tissue, so we have to do a FGG. So 1.5 years later, after 6 surgery, I didn't even count the second stage as a surgery, I'm just counting like implant, bone graft, CTG, FGG, another bone graft, all this. And this is what we get. So unfortunately, bone graft didn't work. So we end up with a huge recession and bone loss on the canine and on the central, and implant was end up placed very deep, and there's no enough calcaneus tissue at the canine. And this is what patients have, like after all the 6 surgery and 1.5 years. And compare what patient came first initially present to you. And I really think this is a very big failure for this case, and I feel very bad for the patient. So again, my point here is like really just think twice when you decide to place implant, okay? And one thing actually I want to point out, and hopefully there's some people like who attend my first part 1 lecture. If not, you can contact Dr. Wu for the access for the first one. If you look at this picture, does this tooth shape ring the bell for you? The tooth shape is very square. So what did I say for the part 1 lecture? If you see a square tooth, there's most likely the patient has altered passive eruption. So when I look back for the surgical picture and I study for it, I say, yes, this case is definitely an altered passive eruption case. If you see here, all the CEJ is way more apical in the like away from the margin, like there's so much enamels hidden under the gum, and the bone is very close to it. So it is a autopassive eruption type 1B. So if right now, if I really look back at this case, and if you ask me if I were the dentist, what I will do, I will first do a mock-up tell patient, listen, you have this autopassive eruption, which means part of your teeth will be covered under your gum. And this is what you will look like if you do the surgery of crown lengthening. And if the patient likes it, I will go ahead to do a aesthetic crown lengthening from canine to canine and a functional crown lengthening on that lateral. And after everything heals, I will just do a new crown on the number on the lateral and the central and bond them together. So in this way, I don't really need to worry about longevity of the new post in the crown because now it has the support of the central. So right now I cannot retest my theory because it's already been done, but I do think with this new treatment plan, it probably will have a much better result compared to what we see here. So again, I want to close the presentation as to emphasizing how important of aesthetic evaluation and periodontal evaluation in both functional crown lengthening and aesthetic crown lengthening. So in the end, I really like this quote from this Italian physician, Enrico Fermi, and I hope you feel the same as the quoting. So before I came here, I was confused about this subject. Having listened to your lecture, I'm still confused, but on a higher level. So thank you very much for the part 2, and that closed my lecture.
Thank you so much, yes. Dr. Shi. Thank you. If you have any questions, you can shoot them forth. Let me see. Let's see if we have any questions today.
Okay. I saw one in the QA. I have 2 questions. First, in case you're showing Ingber procedure, there was exposed root, so will it cover by soft tissue rebound? Second, in Malka procedure, we don't remove a lot of bone. How about tissue rebound and no enough bone removal? Okay, so for the first question, for the Ingber one, I think this is what you mean probably. This is... I don't know if you mean this one. For this recession, there is no tissue rebound. It's set because you touch the bone of the adjacent tooth. So basically, ideally, you don't want to see the tissue rebound after healing. So if you see a tissue rebound, and that's usually not a good sign. So I will say the recession will not be corrected by the tissue rebound. That's the first question. And second question is, I'm going to stop share actually. The second question is in the Melker biological shaping. Okay, that's actually a very good question. And for me, I cannot answer you for sure because I personally didn't really attend Dr. Melker's hands-on courses or something. But just from the articles and the case that he showed, that he doesn't really expecting a very long tooth exposure, because if you go ahead to check his cases online, you'll see all his cases are full arch cases. It's not talking about single crown. It's mainly for the full arch and or like several units together. So I assume he's actually gained retention from this several units together and with a very strong cement. If he end up with not a very long root. That's what not a very long tooth structure. That's what I understand, because he really doesn't remove too much bone. And also, he also mentioned the indication for his biological shaping, which actually he recommended his technique is used for some minor periodontal disease patients. So those cases actually already have periodontal defect. So it's kind of a combined osseous surgery with crown lengthening. So you might not have a super long tooth structure after crown lengthening as Ingeber or Wagenberg, but I think it's enough for him to fabricate the final splint PFM or restoration. Yeah. Okay, so do we have some other question? I think in the QA is only one.
Okay. In the chat, there's a question.
I think answer live. Yeah. In the chat, there's a...
I don't know if it's the same question. So in the Melker technique, after your surgery, how would you temporize the teeth while patient go through the healing in terms of...
Oh, okay. There's actually I didn't want to talk in detail about it, so I didn't put it. I think if I remember right, it's at 4 weeks, they temporize. Before 4 weeks, they don't have temporize. That's what they say. That's what Dr. Macker mentioned in his chapter and the book. He said at 4 weeks, and patient will be able to have a temporary crown. And because at 4 weeks, the suture has been removed and the epithelial healing has been complete. So they will not touch, they will not prep it. They just probably like a feather edge, but everything super gingival, and they will deliver the provisional. And at 14 weeks, approximately 2 to 3 months, and they do the final preparation. So basically the first month patient wear nothing. That's for my understanding. At least they didn't show patient has any provisional. Yes.
Okay. All right. Thank you so much. I don't know if there's another question at the Q&A. Okay.
No, I think it just thank you.
All right.
My pleasure.
I'm going to send you I'll reach you out later, communicate with you to see, because this is not the last. We need Dr. Shi back.
Sure, no problem.
As soon as your schedule, everybody appreciates the material. I mean, what I've heard is that this is excellent material, and this is coming from folks who have been practicing for years. So it's not just newbies like me who are just learning myself. But we really appreciate it. Thank you so much. I really appreciate you. Thank you.
Sure. No, my pleasure. Okay, so bye everyone. Have a good weekend, or the remaining of the weekend, and hopefully I can one day then meet you in person again and see you everywhere, all of the world.
All right.
Okay.
Thank you.
Thank you.
Right. Bye.
Yeah. Bye.
Okay. Yes. We're gonna go. Thank you guys for joining in today. We're gonna have on Sunday. We're gonna have Dr. Erica Benavides, she's going to be here, and we're going to have Dr. Shadi Haji. We're going to start the dental implant course. We're going to start the dental implant course next week. So if you're registered for that course, I mean, it's going to be open to everyone to look at it, but in terms of if you're going to get credit or any participation, there are certain courses that are going to be just exclusive to those who have registered, in terms of, but it is open. Anyone can watch it. But if you're going to do the assignments, if you're going to participate, then you're going to get credit for that as part of your dental implant course that we are organizing. So we do. I just want to see if I can pull up that course here. If you have any questions in terms of logistics or anything, just do let me know. We will see how to. So the course, so we started doing this course because, I did a little research of some schools in Nigeria, and there's an increasing awareness and there's a demand for dental implant options. And most people are not trained to do this just because, it is costly. Most of the people who trained us have not placed implants, so you cannot teach what you don't know. So I decided to kind of reach out to as many as will be willing to do it for free. So this is a free course, and you don't have to pay anything. So this is going to be the course outline. So this follows the American College of Prosthodontics learning areas for implant prosthodontics. I'm still deciding. We're going to have a textbook. 2 reference textbooks. I'm thinking of the one by Carl Mitch, and there's a Perio textbook as well. I'm going to present it. It is be a good material, because I think for whatever exams we're going to have, is we're going to tailor it, after those textbooks. Because those are really, really reference texts, and all the material for the exams are going to be from those books. So you listen to the videos, you do your quizzes, and there's going to be a final exam. There's going to be group work, and we're going to cover the historic evolution of dental implants. We're going to cover diagnosis, anatomy, CBCT, interpretation, grafting and augmentation, timing of implant placement, surgical implant placement, common emergencies. We do have Dr. Aronovich from the University of Michigan, who's going to take, common emergencies. We have osseointegration, biomechanics. We do have several people. I'm still trying to reach out to see how to get some of all these topics covered. But we do have all this material, and they're going to be available on demand. So if you're not able to join the class, you can still, maybe in the second phase of this is going to be via video lectures. But for those who can join us for this first series, it's going to be live, and we do have almost 200 people who are registered already. We have room to take 500, so let's spread the word out. It's free. Let's spread the word out to India. Let's spread the word out to United Arab Emirates. Let's spread it out to dental schools around the world. I believe this is a good adjunct to any dental school, that your students can have access to the best of the best lectures in implants, prosthodontics. I think, it's a good thing. It's a good thing for every school who can participate. Anyway, looking forward to see you guys next. So if you want to apply, you click here, and it takes you to the application page. You submit your forms, and we'll be good to go. So see you guys on the 17th. We're going to have a class, a meeting for all those who have registered, who have been accepted into the course, and looking forward to having a good time with you. Any questions? If you want to speak, I can give you the microphone. Is anybody, you have something you want to say? Dr. Ayad, it's good to see you here. Dr. Ayad, Professor, how are you? Professor Ayad, are you there?
Yes, sir. How are you?
I'm good. Good to see you. Thank you for. I thought you're from Tanta, Egypt.
That's right. Sorry for being late.
That is fine. But it's good to see you here. I'm hoping. I'm trying to find out how do we send this the word. So we're starting a dental implant course that covers most of the things I just talked about. How do you think we can get the word across to to all North African countries, Algeria, Tunisia, Morocco, Cairo, and generally, or the Middle East?
Yeah, I guess I could help you in this matter by sending many requests to my friends, because not all of them are following your series. So I guess I might help you in this issue.
Oh, I would. I always need help, Professor.
I will.
Because I think what we have developed here, we need to share it, and I want to thank you. I got across to someone from Cairo. She has I don't know if you know about her. She has like a blog online where she's beginning to share. But I mean, whatever connections you can. And if you are on here, so what information do you need for me to send to you?
No, I guess I do have all the information I do need. Just I need to, like as I said, get communicated with many of the dental school. As far as I know most of them. So it's my fault that I did not send them that much information to follow your series.
Okay.
But my friend, that the problem maybe is the time difference.
Okay, that's true. So, but most of those courses are going to be on demand, so people can reach out to this even if they don't attend live. I think we are flexible enough to have so far they go on there and watch the video lectures. All the lectures are going to be available on YouTube.
Yeah, I guess that's a good idea. Yes. I guess this is the other idea. But anyway, I could distribute these or some of your slides to them.
Yes.
Then they could follow your series. I guess it's my fault. I should have this done before.
No problem. But, no problem, Professor. I've sent the link. I'm going to email you. Did you get my email from my general email I sent last week?
I guess it's easy. I could get it from my, if you send it to me, I'm sure I do have it. And okay, I could send you, or I make a reply to you.
I'll send the link again. Just a couple, 3 links. One to the website where people can, learn about the, all the courses and the speakers we've had in the past, and about the dental implant course. It starts, and the registration ends on Thursday. On Thursday,
Okay, it's a good idea.
Yes. So once you get onto the, can you see the side, the page I'm showing?
Yes.
Yeah. So they just scroll down here and they can apply click there to apply for the dental implant course. And on all the videos are going to be on this YouTube channel. But the main thing is to click to apply for the course right here. And so once they do that, it takes them to this form. And that's all they need, so when they apply for it, and the curriculum is on there, what we're going to be covering, and hopefully we can bring you back to cover one of the courses. We are still looking for professors that will take on a couple of topics like, biomechanics of implants and stuff like that.
Sure, I'll help with in this matter. I guess I will distribute these titles to my colleague, as I said, in a couple or 3 or more in the dental schools here, so we could find someone to cover these titles.
Okay, all right. Thank you so much. I'll send an email to you right away. Thank you.
Okay, thanks.
All right. Okay. Have a wonderful day. Maria Tariq Hamadi, how are you? Maria, you can speak if you want to. Milad Joffrey, how are you?
Hello, Dr. Uva. I'm fine. I hope you're fine also.
I'm good. Thank you I see you're always on here. Thank you for joining us, and hopefully we can, learn 1 or 2 things. There's so much to learn, so much, and we have willing professors who are willing to teach the curriculum that we have put out, hopefully.
It's always a pleasure. It's always a pleasure.
All right. Okay, Dr. Montaigne. Dr. Montaigne is an excellent practitioner. Good morning, Dr. Montaigne.
Good morning. Good morning. Glad to be here.
It's good to see you. Dr. Montaigne, I need you on the teacher side. I need you to, you have so much experience. I'm just humbled by the fact that you sit to listen to, all these lectures.
We always learn more. So learning has never ended.
You're right. Anyway.
Thank you.
I'm trying to put it together so that we can have it as a course. It covers all the aspects of implant prosthodontics. I think the world is going there, and hopefully we all can learn together.
Yes.
All right. Have a wonderful day. Good to talk to you.
Thank you.
Dr. Shade, you're from Nigeria. How are you?
Hello. Hi. How are you?
Dr. Shade, good to hear you. How's work? How's business? How's training? And how is your interaction with modern trends in dentistry?
Business is going well. Yes, we've been affected by the COVID, but we're back to business as usual, especially in the area of orthodontics, because I do all aspects of dentistry. Yes, there's so much to learn in dentistry, and I can't seem to have enough time to learn it all. So we'll just keep on going.
Yeah.
And thank you so much for all you're doing to make this possible. We really appreciate you.
Yeah, thank you. I'm thinking of how to get it across to, so this course, I'm thinking I can put it together so that we can have all our dental students. So it's a way of kind of calibrating every student so that we all have the same access to the same knowledge, in terms of even just the didactics, that you have, at least you have all the, so every student, I'm thinking, I don't know, is it possible that every Nigerian dental school will have their students take this course for free at no cost to the school? They just need to put in their time and do the assignments and understand the concepts. What do you think? Do you think that is possible?
I think it's possible, and that would be a fantastic idea. I finished from IFE, so I'll definitely put the word out there. And I also did my house job in Lagos, so I would talk to some people, and I'm hoping that everybody will tune in, whether they're practicing or not, because there's a world of opportunity out here. And I think everybody should tap into it.
Yes. All right. Thank you so much. Looking forward to having you, in the series. So it's going to hopefully run for a couple months. I'm still trying to fill in some of our we've covered 60% of the lectures have been, I've been taken already, but we still have a couple more. I'm even looking for professors from Nigeria who are willing to give these lectures, and these lectures are given for free anyway. So that's
yes.
Trying to find those who are willing to give in this term. Well, thank you so much. I really appreciate you.
Thank you very much.
All right. Dr. Uchenna Okechi. Uchenna, we have always talked. You are in Enugu or Calabar?
Okay, I'm in Enugu.
All right. Are you an instructor there? Are you a lecturer at the university?
Yeah, I'm a lecturer in the University of Nigeria.
Okay, nice. The Lions, right? The Lions.
Yeah.
The greatest Lions. I like, every school is great.
I went to University of Benin.
Okay.
I schooled in University of Benin. Then Enugu, University of Nigeria Dental School is the only dental school in the southeast part of Nigeria.
Yes. But I know there's one now in Port Harcourt, right?
Yeah, there is.
Is that considered southeast or south?
Well, south boys is close to southeast too.
Okay, nice. Anyway, so like I said, I'm trying to reach, I don't know, I need somebody to champion the cause for me in Nigeria. To how do we send this across? We do have. I'm truly impressed by all the people from the Middle East, especially Iraq. We have over 500 people from Iraq who are registered. 500. 500. So to my Iraqis right here, yalla. Thank you so much, guys, for. So how do we make this happen in West Africa?
Okay, already I've started talking to people about it in my end, and some of the students are already getting sensitized. So it will be a nice life for them.
Well, I've tried to go through the Nigerian Dental Association through their WhatsApp groups. I've tried to reach out to the students, but not so easy with the Nigerian, and not so easy. I've not been able to get but I know the issues of data. But I understand that the network companies are now allowing people to watch YouTube without cost. Is that correct?
No, I don't think it's so, but I pay for my data.
I see.
All the time I'm online, I pay for my data. But my advice is, I think you should pick some key people, train them so that they can train others.
Yes. Training the trainers. You're definitely right. So that's why I was in Nigeria last year or earlier this year in February to do, just to start the issues. I was at the University of Benin, and hopefully we can do something there. That training the trainers. You're right, because it's almost impossible to. You need people who will champion this, where they are. Yeah, you're right. So I'll log on to. Thank you so much, Dr. Uchechi, for that. Okechi, for that wonderful advice.
Thank you so much. I appreciate all you have been doing. I wish God to give you the strength to continue.
I pray so. I pray so too. All right, we're going to go all the way to Iraq now. Dr. Sarah, how are you? Dr. Sarah Sirag, you can speak if you want to. Dr. Sarah, if you can hear me. Anyway, I'm going to just hold on for a couple minutes here. If anybody wants to say anything, I know that a lot of people, OM Akwang is going to be our student rep in Nigeria. So I need someone to be a student rep from Iraq. So if you are a student in your 5th year or your 4th year preferably, so at least you still have 1 more year to go, your 5th stage. I just want you to be able to say, okay, I reach out to students. I need someone. All right, so Dr. Solomon, I see your comment here, obviously. So for this first set of dental implant course, anybody who applied, every person who applied, of course, there are some folks who did not put any information there. Most people who applied, who sent in their summary, you will get a response from us in a couple of days. Most people have been accepted, so there's no fear about that. We do have the numbers, and hopefully we will have everybody in. All right. By the way, I'll see you guys. I'll see you guys on Wednesday. We do have a lecture that will be coming on by Dr. Ivan. Dr. Ivan is a prolific dental, a prosthodontist. He actually finished from the University of Michigan. So the last day of submission for the summary of the videos, I mean, I guess maybe on the 17th is fine. Yeah. And I just wanted to add here for those who are submitting, some people are using, I can tell you're using a software to just, translate the voice, so it needs to be something that you understand. So it has to be written in such that it's something you got from it, not necessarily what the person is saying. Some folks are using the software to just, download, what the person is saying. The summary is what you got from it. I can tell by just reading it, but we're going to be a little lenient for the first one. But going forward with every course, because you're going to be doing these summaries for all the courses you attend. So you need to at least get something. And if there are any issues with interpretation or anything like that, please let us know. We'll be willing to get some interpretation going on. We can do some subtitle in the language that you would prefer. So on Sunday, we're going to have Dr. Erica Benavides. This is going to be the implant course. This is going to be the implant course. There are 2 courses on that day. She's at 10 a.m. and there's another one at 11 a.m. So you want to attend. This is part of the implant course on Sunday. And we have Dr. Ivan. Dr. Ivan is going to be coming on Wednesday. On Wednesday by 2 p.m. That is the best time we could. So we're going to record that, and we'll see how to play that video for everyone to watch. Dr. Ivan is the implant ninja. Dr. Ivan, implant ninja, very, very prolific guy, hard worker, and we've just been blessed to have all those people willing to contribute to this series. Anyway, I'll see you guys. If you have any questions, if you want to share, let me see if there's any question out there. If not, I'll see you guys on Wednesday. Then on Thursday, you can go. So I want you guys, if you're on there, I know most people are registered. If you are going to our Facebook group, will be good because that's where most of the information will be. So I want to try cutting down on sending out emails so that if you want any information, you just join the group, and most of the information is going to be there as announcements. So everything you need about the course and what is going on, so that you don't miss any information. It's just to join join that Facebook group. The Facebook group is called Dental
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator